Shall we start?
Yes, sir.
So, everybody, good morning and a very warm welcome to this great day, the inauguration of the online anesthesia, this postgraduate teaching program and Zoom platform sponsored by Accrulla and hosted by A1 Logistics. So, this is purely a postgraduate teaching program, mainly to cover the theory classes which they may have missed due to the pandemic. And it is a continuous teaching program on every Sundays. So, until the pandemic situation improves and routine classroom teaching to the postgraduate begins. Then this platform may be converted to practitioners forum. The continuation of this forum for postgraduates depends upon the postgraduates' response. So in addition to the postgraduate program, we have allotted 1 hour for the practitioners covering many sessions like video sessions. The video session is mainly to learn a technique in a week. It may contain ultrasound guided nerve blocks, or it may have a airway gadgets demo. So it will also have journal club sessions to analyze recently published articles, and we will have meet the expert sessions to interview the outstanding personalities in our field of anesthesia, and many more interesting sessions will be added in the due course of the time. And this postgraduate teaching program is a great idea put forward by Dr. Vinoth sir. We are very thankful to him. Another name I wish to mention here is Professor Murugan sir, who has given constant encouragement in conducting this program. I wish to introduce my team members here. Without their hard work, this program is not at all possible. Let me share my screen. So this is an online anesthesia postgraduate teaching program on a Zoom platform sponsored by Accrulla and hosted by A1 Logistics. So these are my team members, young energetic team members, and we have a technical team backing up also. It is an every Sunday program, 10 to 12 every Sunday. So this is Dr. Gomadi Karmekam. He is an associate professor in the Department of Emergency Medicine in Madras Medical College. He has vast experience in establishing and administrating the standalone COVID hospital and emergency department in MMC. And he is very much interested in teaching. And he has very active various association and NGO organizations. We are happy to have Gomadi Madam in our team. Next, I welcome Suprasad sir. I like to introduce Suprasad sir. He is an assistant professor in the Madras Medical College. He is well popular among the postgraduate. He is a great teacher in Madras Medical College. He has vast experience in liver transplant. He has undergone liver transplant training in Sri Gangaram Hospital, Delhi. And his field of interest is cardiac anesthesia. And I like to introduce Rajesh sir. He is a senior consultant anesthesiologist and pain medicine physician in Meenakshi Mission Hospital in Madurai. And he has vast experience in teaching DNB anesthesia students and DNB critical care students. He is very popular among the DNB students in conducting the case discussions. And he has a specialist training in fellowship in pain medicine, and he has a certificate course of palliative medicine also. So I like to introduce Sarva Vinodini. She almost swept the 6 to 7 gold medal when she was in the PG. She was doing PG in 2007. So I think she is the right person to guide the postgraduates to read which books to get gold medal like her. So we are happy to have her in our team. And he has a teaching experience. He worked in a senior resident in AIMS and assistant professor for 3 years. And now she is working as a senior consultant anesthesiologist in Vinoth International Hospital, Chennai. Of interest is pediatric anesthesia, obstetric anesthesia. She has a great passionate towards teaching and interested in research. And Dr. Shantini, she is also assistant professor in Madras Medical College. She has a great skill in organizing teachings, and his field of interest is critical care or cardiac anesthesia and lab anesthesia. So we are happy to have her in our team. And the last but not the least, Guru Sandhya. She is a young aspirant with a great future. He has various awards during her postgraduates. He is a consultant anesthesiologist in Kumaran Medical Center in Coimbatore. He is a young faculty in the RCOA accredited CME EFRA, and he is interested in teaching and giving lectures. She is a voracious reader. Whenever I have a doubt in where to refer, I used to call her for which book we have to refer. So she is a voracious reader. She has such a knowledge. She is going to have a great future. So I have a young generation team, mostly academic team. I hope this will take this venture to a higher. So my backup team, that is tech team, is as usual the A1 Logistic, and my postgraduate Dr. Senthil and Dr.R.Selvakumar. And the program is sponsored by Akrola Pharmaceuticals. They are sponsoring this program not to promote their products, but promote the teachings, that is the postgraduate teaching. We are thankful to Akrola Pharmaceuticals. And this is our social media. This is our contact number, that is onlineanesthesia@gmail.com. We are planning to create a database for the faculties. Those who are interested in giving lectures can send their CV and the area of interest to this mail. They will be included in our teaching program. And our FB page is Online Anesthesia, and we have a YouTube channel also, Online Anesthesia. We have Online Anesthesia Telegram group. For your feedback, you please log in Online Anesthesia Telegram group and give your feedback. Your feedback and suggestions are most welcome. With that, I thank everyone and wish you all a happy new year. Before handing over the session to the main lecture today, that is by Dr.R.Selvakumar on the Respiratory Physiology Part 1. The first lecture, I think, was the basic respiratory physiology. Then I thought of who to introduce the first lecture. So the first name come in my mind is Dr.R.Selvakumar, because he is a great academician and he is very popular among the postgraduates. He will teach not to the front benches, he will teach only the back benches. So he is a absolutely correct person. I think I have chosen for this first lecture. I welcome you, Dr.R.Selvakumar sir. Dr.Selvakumar sir will introduce the speaker. Before handing over, this is a online anesthesia postgraduate teaching program based on Zoom platform, sponsored by Akrola, and it is hosted by A1 Logistics. Thank you. Over to Suprasad sir.
Good morning all. At this outset, I welcome all the participants in this online anesthesia teaching program. It gives me immense pleasure to welcome and introduce our Selvakumar sir, Professor and HOD of Anaesthesia, Madurai Medical College, who is a doyen in anesthesia and an ardent teacher. He is known to simplify tough concepts and teaching from the grassroots. I think for the past 23 years, he has not spent a day without teaching. He is a review board member of the Indian Journal of Anaesthesia and has served as past president and secretary of Madurai ASA. With this brief introduction, I welcome Selvakumar sir to start the lecture program. Welcome,
Selvakumar sir. Before starting that, I welcome Ganesh Prabhu sir to say a few words about this new venture. He is a GC member of National IAC from Tamil Nadu. Welcome you, Ganesh Prabhu sir.
Good morning, all of you. Wish you all a happy new year. I am having a great pleasure in participating in the online anesthesia postgraduate teaching program organized by Edward Johnson. Again and again, Edward Johnson is proving that he is a classical academician. His constant enthusiasm will make him to attain new heights in the anesthesia academic arena. I wish him a great future, and also this online anesthesia program will be a beneficial one to the students. So all the faculties here are younger ones, and they are the products of Madurai Medical College. So I am proud to say that, and I wish this program a great success. Thank you.
Thank you, Ganesh sir. I once again invite Kumar. He is the sitting president of Tamil Nadu IASA. Kumar, can you say a few words about this program?
Yes, sir. A very good morning to everyone. Wishing you all a very happy New Year 2022. As Dr. Ganesh Prabhu sir was telling, Dr. Edward Johnson sir was conducting that Anaesthesia News Today online quiz program and conducting transforming the message to all the postgraduates and the students and the practitioners for a long time. I always wonder how he has time to spend for this time in spite of his very busy professional work. But he's a very passionate teacher and he wanted to transform the message to all the younger generations. Thereby, we can bring change in the future generations. In that process, he has started this online anesthesia program. This is a very welcome approach, and definitely it will benefit the postgraduates and all those practitioners, because he is extending the knowledge to the paid practitioners also. So in that, I wanted to put a quote by Dr. William Arthur. Teaching is not merely in transforming the knowledge, it is an inspiring a change in the students. Likewise, learning is nothing but acquiring the facts. It is acquiring the understanding the facts. That is what I wanted to try that, because teaching should change in the students, and learning should bring understanding about the facts. These two should reach the teachers as well as the students. With this, best wishes for the online anesthesia program. And Dr. Edward Johnson, I wanted to congratulate the entire team. It will go a long way. All the very best. Thank you.
Thank you, Kumar. And last, I invite Professor Murugan sir to say a few words about this, because he is a constant supporter for this program. Murugan sir, unmute yourself.
Good morning. First, I wish Edward a great success for this program, and Happy New Year to everyone. See, when we started having a common class, a forum for our postgraduate according to the MGR University norms, we start with the basic topics, so that we expected the first years to join by December, so that we will start the basic topics. But anyways, it got delayed. Still, we want to go ahead with the teaching schedule. I think this needs all the help from all the HODs of all the government colleges and private colleges, because we want to have a structured, uniform syllabus, so that there will be continuous progress on that part, and the concerned departments also will take care of the rest of the teaching in that subjects, so that the candidates will get good exposure to all the topics, and they will be getting classes from all the teachers from all over the state. So that will be a good thing. Actually, we ran a program called PrEP. The last 2 years we don't have them because of the COVID, where we used to have around 35 professors will be attending the thing and giving case scenario based, exam based training for the students. So I think once the COVID stops, then we can expect that offline program. Before that, this online program will be there, and I think the Edward will take care of all the aspects of the PG. So the PG students should take part voluntarily. That's very important, because just like that, joining the course online program and not attending the actual program will not benefit them. So I ask all the postgraduates to join and utilize the service. All the best, Edward. Thank you.
Thank you, Murugan sir. I can see Ravindra GL is joined in our program. Sir, are you online?
Yes, Edward, I'm very happy to be online.
Thank you, sir. Yes, you can say a few words about this program, sir.
Excellent program, Edward. As usual, see, I have been an ardent follower of your group for a long time. Of course, busy schedule, I might miss a few of your quiz programs and such things, but it is an excellent tool for the postgraduates to learn. It has been a fantastic thing. It's a fantastic journey, and we'll hear it from many consultants. And Selvakumar is an excellent friend of mine, my PG mate. We did our post graduations together. I'm very happy to listen to him.
Thank you so much, sir. Sorry, Selvakumar sir, for holding you for a few minutes. Over to you, sir.
Yeah. Right. Hi, Selva. Welcome.
Sir, tell him to unmute, sir.
Selvakumar is not audible.
You are not audible.
Selvakumar,
Selva, sir, please unmute, sir. Not audible, sir.
Selvakumar, you are not audible. Still not audible. Edward,
Is checking this speaker. So until he joins, so today's program is the first theory topic of respiratory physiology. It will be a first part. Second part next week I will take. Then it will be followed by a video session by Vinoth Kumar, the insight into the supraclavicular block, and that will be followed by a quiz program. This quiz program is only the questions will be taken from the class which the Selvakumar is going to take today. So the questions will be pertaining to this topic only. So the postgraduate, please listen to the topic carefully.
Edward, make Selvakumar audible.
Okay. Selvakumar sir.
Selva, sir, K7 install பண்ணிருந்தீங்கன்னாக்க அது block பண்ணும்.
Shilpa, can you
Yes,
start the video session? There is a problem with audio. It will come out in 15 minutes. We will run the video session now. Guru Sandhya, over to you. You introduce the Dr. Vinoth Kumar. Guru Sandhya,
Yes, sir.
you introduce the speaker.
Okay, sir. Good morning, everyone. I'm Dr. Guru Sandhya. I'm extremely happy to be a part of this team and to help the postgraduates learn. I'm here to introduce Dr. Vinoth Kumar Ramachandran, who has been my colleague. Along with him, Dr. Karthikeyan has been my mentor in ultrasound-guided regional anesthesia techniques, who would not inject even 1 ml of a drug without seeing the tip of the needle. He has completed his UG from Kumaran Medical College, his PG from Madras Medical College, and fellowship in regional anesthesia from Ganga Medical Center, Coimbatore. Here is his presentation into the insights of supraclavicular plexus block in the in-plane approach. Over to you, Dr. Vinoth Kumar.
Shilpa, you can play the video.
Good morning, everyone. I am Dr. Vinoth Kumar, and I would like to thank Dr.R.Edward Johnson sir and the entire organizing team for this great initiation and for giving me this opportunity. And I request all the PGs to utilize this platform every Sunday from 10 a.m. to 12 p.m. And today we are going to see supraclavicular block. So it is a commonly performed technique, and we are going to see the block through these headings. And we know there are a lot of techniques for the brachial plexus block, interscreen block, supraclavicular block, infraclavicular block, and recently introduced costoclavicular block, axillary block, and the individual peripheral nerve blocks. But today we are going to see only supraclavicular approach. It is a commonly performed technique and otherwise called spinal anesthesia of the upper limb, because at this level we can block all the trunks and divisions. And the commonly performed block for the surgeries below the shoulder. So this is brachial plexus block anatomy formed by the primary ventral rami of C5 to C8 nerve roots and the first thoracic nerve root. And roots forms a trunks, upper and middle and lower trunk, and trunks divides into anterior and posterior divisions, and the divisions unites to form the cords below the clavicle, lateral, posterior and medial cords, and finally terminal branches. So at this location, this you can see the arrangement of plexus in the supraclavicular area. See, the upper trunk is the most superficial one, which is formed by the C5 and C6, and the middle trunk is formed by the C7, and the lower trunk, which is the deepest one, close to the subclavian artery and the first rib, which is formed by the C8 and T1 nerve roots. We are going to perform block at this level, and you can reliably anesthetize the inferior trunk in this approach. Usually it is paired in the interscalene block, and also less chance of diaphragm dysfunction when compared to interscalene block. So brachial plexus innervation, so it supplies the entire upper limb except upper medial part of the arm, which is paired in brachial plexus block, which needs additional infiltration of the local anesthetics. So what is the important consideration at this location? You can see the proximity of the plexus to the chest cavity content. You can see the plexus subclavian artery, and below the subclavian artery and the plexus you can see first rib crossing the structures, and below the rib you can see the pleura, anterior and posterior to the rib you can see the chest cavity content. So what is the concern? You can see everything is closely packed. So with the aid of ultrasound imaging and the real-time monitoring of the entire anatomy and the entire needle visualization throughout the block, you can avoid the unnecessary complications and increase safety of the block and increase safety to the patients. So next important step is always put in a proper positioning. By keeping the patient in proper positioning, we can easily do the block. You can compare both the images. See the left side of the image and right side of the image. Both images are different patient. One is the left side of the image, lean individual, and right side of the image, obese, short neck individual. What we have done, we have kept the pillow under the contralateral of the head. Don't keep over entire head, contralateral of the head, and also ask the patient to adduct the arm. By doing these two important maneuvers, you can get the more working space. You can see the working space here, so you can do the block easily. And also, right side of the image, the folded sheet kept under the ipsilateral shoulder. This is more useful when the patient, you are getting the patient with obese and short neck individual, will get more working space to perform the block easily. So always follow the ergonomics. Keep the ultrasound machine at your eye level. So always do the block with the proper sitting position. So next is keep everything ready. Ultrasound machine with the linear transducer probe and the standard nerve block tray, 5 cm 22 gauge short bevel insulated needle. Ideally, if it is not available, you can go with the blunted tip 23 gauge spinal needle. Depends upon the local availability, and also 20 to 25 ml of local anesthetics, either 0.5 bupivacaine or 0.5 ropivacaine, and also 3-way extension tube with the saline loaded syringe. Always do the hydro dissection before giving the local anesthetic. So I would like to share important landmarks. You can see the landmark here. So you keep the probe parallel and posterior to the mid-clavicular point. So if you have difficulty in locating this midpoint, you can see the clavicular head of the sternocleidomastoid. You ask the patient to raise the head. You can see the clavicular and sternal head. and posterior to the clavicular head is the mid-clavicular point. Most of the time, you keep the probe here and start to scan. So always do the pre-block scanning, because by doing the pre-block scanning, you can get the idea about the anatomy, whether any anatomical variations and the structure surrounding the plexus. You can see and get the proper orientation before doing the block. We are doing the pre-block scan from interscalene to supraclavicular area. Actually, this is a short neck patient. You can see the ultrasound image, corresponding ultrasound image, traffic signal sign in the interscalene area, and trunks in the supraclavicular area. See, after keeping the probe, how to start scan. So what is the reference point here? Always, most of the time, you will get some vessels in all area. Here is a subclavian artery is a reference point. So by keeping the probe, most of the time you will get the subclavian artery. Suppose if it is, and one more important thing, posterior and lateral to the subclavian artery, you will get the plexus most of the time. Suppose if it is not visible, by doing the transducer orientation, like clockwise rotation, or else inferior or caudal tilt, both can help to get the plexus in a proper ultrasound image. So by doing the clockwise rotation, inferior or caudal tilt, you can get the plexus which is posterior to the subclavian artery, as well as chest cavity content also you can able to see by doing the inferior or caudal tilt. So yeah, we have kept the probe posterior to the midpoint of the clavicle, and imagine this is the transducer from lateral to medial. You will get the structures like this. This is the left supraclavicular fossa. So you will get the plexus, most lateral one, and the subclavian artery. Below the artery and plexus, the rib will cross the structures, and anterior and posterior to the rib, you will get the chest cavity content. So you can see this is a very, very important image. From lateral to medial, as I said, you will get the plexus and the anechoic structure subclavian artery, and the two hyperechoic linear structure. So this is the first rib and this is the pleura. So how do we know? Because below, deep to the rib, there is an anechoic shadow, and deep to the pleura, you will get the lung tissues. So you can see in this video, and also you can see the plexus nicely with the sheath containing brachial plexus, subclavian artery, first rib, and the pleura. So needle entry from the lateral to the medial direction, targeting the brachial plexus. One more point I would like to share is, you can see the septae in between the plexus in this video, and also you can see the sliding sign, the pleura movement during the respiration. By asking the patient to take a deep breath, you can see the sliding movement. So it's called sliding sign. So we are going to see the proper technique in this image. So what you have to do is, after skin and transducer preparation, infiltrate the local anesthetics 1 centimeter lateral to the transducer, and introduce the needle in the long axis of the transducer and try to visualize the needle tip. If the needle tip is not visible, better don't advance the needle. Try to visualize the needle tip and try to reach the corner point first. We have 2 injection point. One is at the corner point. You can see in this image. Actually, we did a small mistake. I request PGs don't go through the plexus. You can see we are targeting inferior trunk corner point, which is close to the subclavian artery and the pleura, and we are depositing 8 to 10 ml of local anesthetics. And another injection is, after depositing in the corner point, you just withdraw the needle and target the superficial aspect of the plexus. We are targeting here upper and middle trunk. So below the upper and middle trunk, in the superficial aspect of the plexus, we are depositing another 8 to 10 ml of local anesthetics. And after deposition, the plexus is pushed upward. You can see in this video. So these are the 2 injection points. So you can see the drug spread after the injection. So you can see the drugs in between the plexus. So here is an important point is always put a color Doppler during the pre-block scanning and see any structures crossing there. Why it is important? You can see lot of anatomical variations, dorsal scapular artery, transverse cervical artery, and the suprascapular artery, all arteries crossing the brachial plexus. So by doing the proper scanning and color Doppler, we can able to see anatomical variations and try to avoid unnecessary intravascular injections. So always do the hydrodissection before the block. There are other techniques called parasagittal technique and the oblique technique. Once you are skilled in ultrasound, you can able to do the other techniques also. But today we have seen only in-plane technique. Another important complication, intravesicular or intraneural injections. How do we know we are intravesicular or intraneural? There is a device called a injection pressure monitor. You can see here, this is a device injection pressure monitor. During injection, if the pressure is more than 15 psi, we are not supposed to give the drug. If the pressure is less than 15 psi, you can give the drug. But without, I don't think it is available. So better feel the resistance. If you feel more resistance during injection, don't give. And whenever the patient says pain during the injection, don't give the drug. You just withdraw the needle and see the resistance and see the patient response and proceed with the drug. This is very important step. Suppose if the needle is not visible, what may be the possibility? You may be out of the linear axis of the transducer. So this may be the cause for the if the needle is not visible. So always try to maintain the needle in the credit cord thickness of the transducer. So once you reach the credit cord thickness, you can the needle will be always visible in the ultrasound. Suppose if you are in the correct plane but still not visible, don't take the needle out. Better do the sliding movement of the probe over the needle. Suppose you entered in the proper direction but still needle visible, you by doing this sliding movement, this is actually a very fine movement. You can see the needle in the image. Important complications are phrenic nerve involvement, which is still it is possible with the supraclavicular approach, but it is 100% with the interscalene block. But here only 30 to 50% of the patients, but still it is high. And also 27 to 30% decrease in the respiratory function. This is very important. Suppose if you think this patient is your patient is already compromised respiratory system like COPD and chronic lung disease, the patient may not tolerate this decrease. You better go with the infraclavicular block or costoclavicular block. So another important complication, pneumothorax and hematoma, still possible. So with the help of ultrasound, you can avoid the complications. So this is the most common complication, hemidiaphragmatic paralysis. See the left side of left video, which is normal side. You can see the hyperechoic diaphragm here, which is moving nicely, and diaphragm excursion also seen in the M mode. This is a normal side. Here the block side, right side of the right side video, you can see above the spleen, diaphragm is, the movement is grossly reduced after 20 ml of 0.5 bupivacaine. So patient started to desaturate up to 92%. We kept O2. Most of the time it is we are able to manage, but if you think there is a compromised respiratory system, better go for infraclavicular block. So this is the scenario with rib fracture with pneumo or hemothorax on the contralateral side with ICD in situ, but surgeon wants to operate on the opposite side. Will you do supraclavicular block? Yes. It depends upon the clinical situation and the individual anesthetist. It is not 100% contraindicated. You can do, but the safer technique would be infraclavicular or costoclavicular block if the opposite lung is compromised. These are the take-home messages. I would like to share. Always explain to the patient, since you are going to perform in the neck, most patients will be anxious. So always explain the patient. If needed, go with sedation. Do the pre-block scanning, color Doppler, and don't advance the needle if it's not visible. And always do hydrodissection before injecting the drug. Ideally, every 3 to 5 ml. Don't use 20 ml. It is advisable always to use the 5 ml or 10 ml for giving the local anesthetics. And stop giving injection when the patient complains pain. You may be intraphasicular or intraneural. And I would like to thank all my teachers and all my mentors for this opportunity. And thank you very much.
Thank you, Dr. Vinoth, sir. That was indeed quite enlightening. Herewith we have ended the video session. Over to you, Dr. Edward Johnson, sir.
Thank you, Vinoth, sir. It's a very simple and educative video. You rightly mentioned the diaphragmatic paralysis can occur in supraclavicular block also. So we have done a research paper on this, noting down the diaphragmatic paralysis with ultrasound guided in different volumes of supraclavicular block, and we found even 20 ml there is a 22% chance of diaphragmatic paralysis. We have presented this research paper in the PG assembly 3 years back in USA and got that prize. And the paper is going to be accepted for publication in recent journal. It will be published in this month. There is Saudi Journal of Anesthesia. Thank you. We will see whether Selvakumar is ready. Selvakumar, sir.
Sir, we are checking in another meeting, Dr. Selvakumar's audio video. You can proceed with the next one, sir.
Without the topic, we are going into the quiz topic. Sorry, actually, this should have come in the last after the topic. Anyway, we will go to this quiz topic. So, during the first minute of apnea, the PaCO2 will rise, whether it is 2 mm or 4 mm or 6 mm or 8 mm. Shilpa, you can go for a poll. Shilpa? Yes, you can log in on the answers here. So most of them are going for 4 mm. Okay. So Silva, share the results. So it is 53% they have opted for 4 mm and 20% only opted for 6 mm. So we will see the answer. So during apnea, the PaCO2 will increase approximately 6 mm during the first minute, and subsequent minute it will increase 3 to 4 mm. So the apneic oxygen we are using the Thrive, that is transnasal humidified rapid insufflation ventilatory exchange. So there are half a dozen papers are published on this apneic oxygenation, and they have come to a conclusion that the safe apnea period can be extended up to 55 minutes. Provided the catheter is in the trachea. So the safe apnea period means the desaturation has to fall below 90%, because you know in ODC after 90%, there is a steep fall in the ODC curve that corresponds to 60 mm of mercury of oxygen PaO2. So you have to be careful and you have to go up to the 90% saturation in the ODC curve. In healthy pre-oxygenated patients, the safe apnea period you can prolong up to 8 to 9 minutes compared to 1 or 2 minutes in the who are breathing room air. So look into the apneic oxygenation. What is the mechanism behind the apneic oxygenation? There are 4 mechanisms in apneic oxygenation. Suppose you are using a HFNO, it will increase the airway pressure in the trachea and bronchi. And also it replaces the anatomical dead space with 100% oxygen. So it will cause a mass flow. What is mass flow? The uptake of oxygen for every minute will be 250 ml per minute from the alveoli. At the same time, only 8 to 10 ml of the oxygen, carbon dioxide are expelled into the alveoli. The remaining will be buffered in the capillaries. So there will be a difference of around 200 to 230 ml volume of gases in the alveoli. That will cause a subatmospheric pressure. So that causes movement of the gases. The 100% oxygen, it is already in the positive pressure in the trachea, that will move into the alveoli and ventilate during the apnea period. And it also washes out the carbon dioxide. This is the one mechanism. Second is dead space is replaced with 100% oxygen. The third mechanism is the cardiac oscillation. So during the apnea period, your cardiac movements, systolic and diastolic, can compress the lung rhythmically, and that will cause a rhythmic or pulsative flow of the oxygen into the alveoli. So these are the factors that cause the apneic oxygenation. So going to the second questions. Meantime, Selvakumar sir, if you are ready, you can ask me to stop this, sir.
Edward, am I audible?
Yes, audible.
Yeah.
Now, are you ready, sir?
Yes.
Okay, we will move on to the lecture. We will come to the quiz last. Thank you. Over to you, Selvakumar.
Yeah, now am I clear? My screen is visible and am I audible?
Yes, you are clear and audible, sir.
Yeah, sorry for the initial trouble. Anyhow, lung is, the hiccup is related to lung physiology, you know. So there is we should accept the hiccup also. Anyhow, have you ever thought that why the field of anesthesia has grown through the lung? When I used to think about it, when our historians or our predecessors attempt to anesthetize a person, they first did through the lung. So the inhalation anesthetics till now it dominates. So no other specialty in medicine has got the lung as a route of administration except pulmonary medicine, which is a very short, for the past 10 years, they are trying to nebulize and give the drugs. Even now, pulmonary medicine, they are relying upon the other drugs, tablets and other injections, not the inhalation route to a certain extent. But ours is the only field which we go through the lung to reach the patient's brain. So that's why we need to know the lung physiology thoroughly, so that our weapons, they reach the brain to quieten the patient. So my lecture, I have made this lecture as a question and answer type. I have tried to ask some questions and I'll answer myself, some basic questions, right? So if anybody of you have the habit of washing your clothes now, even now in the days of washing machines, if you happen to notice a soap bubble on the bathroom floor, if you notice, one of the bubble will slowly grow in size and our other bubble will empty into it and it will burst. After 10 minutes, you will not be able to see any bubbles. All of them will rupture. Have you ever thought that the lung, which is also just like soap bubbles, why it also resembles the soap bubbles? So why it doesn't happen in our lungs? There are millions of alveoli, just like balloons or grapes. So one alveoli can easily empty into another and it will make the size of the another alveoli bigger, and another alveoli can rupture and this alveoli can collapse. But you know very well that this doesn't happen. So here, have you ever thought that why it is happening? Let us take the help of the Laplace law. What it does is, what it says is, the Laplace law is nothing but 2T by R. That is, the pressure inside any bubble or alveolus, which tries to collapse it, is given by the formula twice the tension divided by the radius. So first you take the bigger alveoli, the radius is 4. The radius is 4, and the tension, for example, we'll take it as 10. It is an imaginary number. So if the tension tries to collapse the alveoli is 2 into 10, and the radius is 4, the ultimate force which tries to collapse the alveoli is 5. So likewise, when the alveoli decreases in size and becomes a smaller alveoli with the radius of 2, what happens? The same tension is there to collapse the alveoli, 2 is to 10. Divided by 2, the radius, it becomes the ultimate force to collapse the alveoli becomes more, double the pressure, more than the bigger alveoli. So naturally, this alveoli should collapse because the force increases. But this doesn't happen. Why means the reason for it, why this tension is there inside the alveoli is because of the surface tension. Surface tension is nothing but any liquid in its surface, the molecules will have an attractive force. They'll try to achieve a smaller shape. That's why the raindrops, they reach a teardrop size or a globular in shape. The surface tension of the liquid make it as globular or teardrop. Likewise also, in our lung also, the air fluid interface inside the alveoli, that is inside the alveoli, a thin film of fluid is overlying in the alveoli. That will exert a tension called surface tension. This will try to reduce the radius of the alveoli, will try to collapse. But this surface tension has to be there, then only the lung can collapse again. After inflation, the lung has to collapse along with the elastic tissue. This surface tension plays a very major role in making the lung collapse, passive expiration. But this tension has to be kept in control, otherwise the lung will collapse completely. So that's why nature has created a molecule, the surfactant, by chemical name dipalmitoyl phosphatidylcholine. This surfactant will reduce the tension, surface tension. What is the use of reducing it? Just again apply the same formula, same alveoli and the same Laplace law. So here the tension remains the same when it is bigger alveoli, so 5. When it reduces size, this surfactant will come into the picture and reduces this pressure into 5, so that the ultimate force to close the alveoli or collapse the alveoli remains the same. So the tension will not increase even if the alveoli becomes smaller in size. So that's why if surface tension is not reduced by the surfactant, the atelectasis happens. That's what happens in the infants. In ARDS, because of the lack of surfactants, the alveoli collapse and RDS results. And also, when the surface tension is reduced, the next cycle of inspiration, we have to spend lesser energy to expand the lung. That's why the role of surfactant becomes very, very important. So in its absence, infant respiratory distress syndrome will result, and also atelectasis and collapsed alveoli will result even in adults. So the very, very important role of surfactant has to be understood. And following surgery also, if the patient takes deep breath instead of shallow breaths, if the patient takes shallow breath because of pain, abdominal pain, what happens? The surfactant will not be distributed all over the alveoli smoothly. So the compliance will come down and the expansion of the lung will get affected, and that will result in so many problems and atelectasis and hypoxemia. That's why even during chronic ventilation in ICU or postoperative ventilation, the sigh mechanism is designed. That is for just expanding the alveoli a little higher so that the surfactant production will be more and the surface tension reduction will be efficient so that atelectasis doesn't occur. So that is the basic of inclusion of sigh in ventilators, some ventilators. Sigh is nothing but a double the tidal volume. Normally, if you set 500 ml, sigh volume will be 1000 ml. So it expands the lung so that the surfactant, the distribution and production will be enhanced. So you can notice in so many ventilators, I don't know whether the present day ventilators include sigh mechanism. In our days, we used to have sigh, and if you put it on, that will give a 4 or 5 breaths in a minute, in an hour, so that the alveoli is completely opened up to make it easy for ventilation distribution to get matched. Then coming to the next question, how ventilation is matched with perfusion? Why this question has come? Because you know very well that ventilation is beautifully done in the upper lobe, and because of the gravity, the lower lobe perfusion is very good. So when the blood goes to the lower lobe and the air goes to the upper lobe, the matching may not be perfect. So what to do? Before you know how it happens, you should know what is transpulmonary pressure. This is nothing but what is the pressure inside the alveoli and what is the pressure inside the pleura. So pleural pressure, we know it is negative. So alveolar pressure, it is the relationship between the alveolar pressure and pleural pressure. Whichever wins, it will try to expand the lung or collapse the lung. So what happens in an erect posture in a lung? You know these alveoli are smaller in size because of the gravity, and perfusion occurs beautifully here. And you know very well that the perfusion is position dependent. The alveoli here are not that perfused. So naturally, this mismatch should not occur. So what happens? The ventilation, how it is diverted to the lower lobe where the perfusion is beautiful, that you have to understand that this is to remind you that the lower lobe perfusion is constant and more, the upper lobe perfusion is less. So just to tell you the principle of how it is matched, you should understand the just how we are blowing up a balloon. So the balloon, when you are trying to inflate it as a new balloon, what happens? You have to use more pressure initially. At that time, even if you use more pressure, the volume change, that is the increase of size of balloon, may not be much. Likewise, at the end also, now if you see, now also, if you increase the pressure, the volume change is not much. So I can say the volume change at the smaller size and the biggest size will be very less compared to what you are giving, what you are trying to force the air inside the balloon. But in between, when you use even smaller pressure, the volume change will be high. So let me say the pressure change, the volume change because of what you are giving pressure will be optimal in the mid size of the balloon. That's what it happens here. So the lower alveoli will be like a mid-sized balloon. So even with a minor force, smaller force, they can expand beautifully. But the upper zone alveoli are like almost they have reached the full size, the last moment balloon. So even if you use more force, they will not expand much. So naturally, these alveoli will be in the ideal position of the compliance curve. That is, you use minimal pressure, they expand beautifully. So the air preferentially goes to the lower lobe to make it matched with the perfusion. That's how the size of the alveoli and the perfusion and ventilation is beautifully matched. So that's what, so if it is matched in normal lung, if it is beautifully matched, what happens? That's what happens. The arterial pressure is high here and alveolar pressure is the last one. So the arterial perfusion is beautifully done in a normal condition. When hypovolemia occurs, what happens? The alveolar pressure in the arrow, this arrow, the alveolar pressure becomes more because arterial pressure becomes less. So what happens? The vasoconstriction occurs. So these two zones, upper and middle zone in a hypovolemic patient, the perfusion will not be good. So naturally, VQ mismatch starts occurring. When you combine hypovolemia with PEEP, what happens? The alveolar pressure increases in all the zones and arterial pressure becomes low because of the hypovolemia. So what happens? In all the zone, arterial pressure becomes low and alveolar pressure dominates. So vasoconstriction occurs in all the zone. So perfusion decreases, but ventilation is maintained. So there is dead space ventilation is increased. So patient is prone for hypoxemia. That is how the PEEP alters in a situation of hypovolemia and upsets the ventilation perfusion match. So next question is, have you imagined a lung completely collapsing during expiration? That means you want to expel all the carbon dioxide. Don't allow the air to be remaining in the lung. You expel completely and then you begin a new inspiration to fill the lung. Why this is not happening? So that's what it occurs. You breathe completely to the total lung capacity. The inspiration occurs, the lung expands. When you start expiring completely, whatever you can, you just push all the air out of your lung. The lung reaches a capacity. Thereafter, you will not be able to expire. That volume is called residual volume. So you cannot expel the air, residual volume out of your lungs. So some of the air remains in the lung, and the same thing, this is forcible expiration. This is after a normal expiration. Some amount of air is there in the lung. Why? Because the inspiration and expiration and respiration is a continuous process, inspiration and expiration, but perfusion is a continuous process. So even blood comes during the expiration. So the blood has to take some oxygen. That's why some oxygen is left out in lungs during expiration. So otherwise, the oxygenation will be a basic phenomena in the blood supply. So to avoid that, there is some air in the lung. And most importantly, for favorable respiratory mechanics, if lung is allowed to collapse like this completely, then they'll act as shunts. There is no air, perfusion will continue. So they'll act as shunts. And for the next inspiration, the person has to use more pressure, more force to inflate these alveoli. So the work of breathing will increase. So to avoid this, nature has devised that always some air remains in the lung as FRC, so that the lung doesn't collapse completely. So the next inspiration will be easy. Oxygenation will become a continuous process. So that is the importance of FRC, right? There is something other thing called closing capacity. That is in between residual volume and your FRC. That means the amount of lung you expire to the normal expiration. And when this is the normal expiration, suppose if you take, and now you try to squeeze your lung out. You try to breathe forcibly out to your residual volume. At that time, what happens? Slowly, the airways become smaller and smaller when the lung size decreases. At one point, the smaller airways will try to collapse when you forcibly exhale. So this point where your smaller airways start collapsing at which lung volume, that is called closing capacity of the lung. So why this is important? Because if FRC is more than the, so I have told you when the lungs collapse, when the alveoli collapse during the normal expiration, then shunt will dominate. So hypoxia will occur. So what happens? This is the FRC, this is the closing volume. So if the closing volume is equal to FRC, that is FRC if it reduces, that means at the end of normal expiration, the smaller airways will close. So even during normal expiration, if the smaller airways collapse, then automatically that lung units will become shunt units. So naturally the hypoxia will result. So at the end of normal expiration, the airways should not collapse. That means the FRC should be always more than the closing capacity. Then only the hypoxia will not result. But it is not so. Closing capacity may equal the FRC, or even if it exceeds FRC, if a person is a smoker or a morbid obese person or elderly person. And also it is position dependent also. At the age of 44 years, closing capacity equals FRC in supine position. So whenever the closing capacity or FRC decreases to approach the closing capacity, naturally the person will be prone for hypoxemia. That is the end result of reduction in the FRC. Then with that knowledge in background, we'll see what happens to the respiratory function under anesthesia. So first and foremost is the FRC reduces. So I just told you, if the FRC approaches closing volume, then the problem of hypoxia occurs. So the FRC should not reduce, but under anesthesia, once the patient is induced, the FRC reduces. There are many reasons for it. Why? The main reason is the diaphragm will occupy a more cephalad portion. Once you induce, the end expiratory tone of the diaphragm goes up and it occupies, at least it ascends 4 centimeters, so that it collapses the lower part of the lung. So the FRC reduces. Naturally, once the FRC reduces, it approaches CC, so that even during normal expiration, end expiration, the airways will start collapse and consequences will be there. And another thing is the muscle tone change, the thoracic cage and abdominal muscle. The abdominal pressure increases, and also the transthoracic diameter also decreases in anesthetized person. So the transthoracic pressure, the diameter decreases, the diaphragm occupies a more cephalad portion. So naturally, the lung occupies a smaller volume in FRC, which approaches the closing capacity. So the zone, lower and mid zone also, all the airways, when they start collapsing, naturally the shunt fraction of the whole lung, the half of the lung will behave as a shunt. So naturally, the person is prone to get hypoxia. And another thing is, when you give muscle laxants, likewise, the abdomen will have a pressure of 1 centimeter of intra-abdominal pressure, and thorax will have a reduced pressure. So naturally, the abdomen contents will try to push the diaphragm up. So naturally, the diaphragm has to generate more force to push the diaphragmatic, the abdominal content down. If it is not, patient is not ventilated. In spontaneous ventilation, if the force is not generated, in controlled ventilation, if it is not pushed properly, naturally the atelectasis of the lower lobe will happen, and because of the reduction in the FRC. And another thing is, even various positions during anesthesia, they also have an impact on the FRC. The Trendelenburg, the supine, and steep Trendelenburg, the steep head-on will reduce the FRC further, and it will have an impact on it. Then pattern, ventilation pattern, especially in immediate post-op period, when the patient breathes shallowly, naturally, this will also promote atelectasis. As I said, a shallow breathing will promote improper distribution of surfactant, and atelectasis is promoted, and FRC also reduces. Then light anesthesia. Light anesthesia again favors shallow rapid breathing. Again, it may also reduce the FRC and favoring the collapse of the alveoli. The next comes the airway resistance. The airway resistance, once anesthesia induced, the airway caliber reduces because of the lower lung volume. So the airway caliber also depends upon the volume of the lung. When the lung volume decreases because of the reduction of FRC, naturally the airway caliber also reduces. And also, if you put a smaller size tube, these things contribute to the increase in the airway resistance. The airway resistance also increases. And if you give high inspired oxygen concentration, I have seen people giving 50, 60%, 70% oxygen, reducing the nitrous oxide. Higher amount of oxygen will also favor absorption atelectasis. That will also result in hypoxemia. Then, because of the dry inhalation of your anesthetic gases, oxygen is very dry, and that too nitrous oxide is also dry. With high FiO2, if you give, that will dry the secretion. They'll obstruct some of the airways. Again, the shunt phenomenon increases. That is, make the patient prone for hypoxemia. So there are many reasons. Once you induce, because of the reduction of FRC, increased airway resistance, because of your positioning, so many things favor hypoxemia. That's why they say a minimum of 33% oxygen is a must when you induce a person. So even though the person was able to live, dance, run with 21% when he was before surgery, once under anesthesia, you have to give a minimum of 33%. For this reason, you have to increase the FiO2, but not too much. So we are just halfway through our lecture. I hope it is not boring. I want your full attention. Otherwise, Deepika will be very angry with you. Don't lose concentration, right? Going to the fifth question. Next is the elasticity of the lung. You know very well that the lung needs an elastic nature. It has to expand, it has to collapse. For both the things, it needs elasticity. So it has got elastin and collagen. Elastin is distensible and stretchable. So during inspiration, it allows the lung to become distended. But collagen, it pulls back the lung to its original position. So always there is a competition between distensibility and recoil. So what we worry about is the distensibility. So the distensibility is measured by what do you call it as compliance. So what do you mean by compliance? Again, you take the example of balloon. So what is the size of the balloon increases for the effort you are putting in. You are increasing the pressure, you are blowing the air inside it to increase the pressure. The volume change of the balloon, how much it volume changes. So the initial period, the mid portion and the last portion. So naturally, this portion will be the whatever effort you are putting, the volume change will be high. So this we say the compliance is very high. That means for the effort you are putting, it is easily distensible. Here also, you are putting too much of pressure, but the volume change is not much. So the compliance is low. Likewise, here also the compliance is low. So if the lung unit is very large, like in emphysema, there also compliance becomes low sometimes. And if it is a fibrosed one, there also compliance will become low. So compliance again is divided into static and dynamic. Static is when the lung is, there is no air movement. At that time, how much it has expanded because of your pressure. Dynamic includes the lung volume change on a move. That means the dynamic compliance include airway resistance also, because it is a continuous process. When the air moves in, what is the change? This amount of air moving in will depend upon the airway caliber also. So when you want to measure the dynamic compliance, it will include both the distensibility of the lung and also airway resistance. If you want to measure the static, that means it includes only the distensibility of the lung. So when static compliance is normal and dynamic compliance is reduced, that means patient has got nothing to do with the distensibility of lung. That is, fibrosis is not there. There is no fluid, but airway resistance has become more. So treat the airway obstruction, not bothering about the fibrosis or distensibility of the lung. That is the difference between dynamic and static compliance. So that's how the transpulmonary pressure is measured and put it in the x-axis. When you increase the pressure, what is the amount of lung volume increases? So that is charted, and that you call it as the compliance. This is one case which I came across. See, first the dynamic compliance was 20 ml. So I have put I wanted to know the static compliance also. So what I have done is I have stopped the breathing on inspiration. So I press the button inspiratory hold. So you can see the airway curve. It shows the respiration is stopped, and it shows the dynamic compliance after it. Now you can see the respiration is stopped, and it is stopped in the midway here. It stops in the inspiration. So when the inspiration is held, at that time the distensibility is measured. So it is shown as the static compliance. Here it will be around 50. So after some time, after 3 or 5 seconds, it will show the static compliance. So I have pressed the inspiratory hold now. And this is the person, for that I have done the compliance testing. The whole lung upper lobe, right side upper lobe is consolidated. So the compliance has gone down. So both the compliance has come down. So I have to, naturally, the treatment should be towards the treatment of that consolidation. It was due to aspiration. So once the aspiration was treated, slowly the compliance became normal. And we could see the improvement into both the compliance on the healing of the consolidation. So as I said, the dynamic compliance incorporate airway resistance and also the distensibility. The formula here I have quoted, how to calculate the static compliance, the tidal volume divided by plateau pressure minus P, and dynamic pressure, tidal volume divided by peak inspiratory pressure minus P. So you can calculate by looking at the value also, so that you can calculate the distensibility of the lung. For example, a patient develops ARDS and on a chronic course, slowly when the compliance goes down, that means the lung fluid is not at all driven out. So still patient is having decreased compliance. So once it is not improved, you will not be able to wean him out, right? And likewise, so this is the compliance curve. In fibrosis, what happened? Even if you increase the pulmonary pressure, transpulmonary pressure, the distension of the lung will not be much. The increase in the lung volume will not be much in fibrosis. This is the normal curve, and this is the emphysematous curve. Initially, because of the lack of elastin and collagen, destruction of the tissue, the lung will overexpand. The TLC will increase, the distensibility will also increase in emphysema. So coming to the next question, what is the significance of airway resistance? Airway resistance is nothing but when you blow the air into the lung, into the airways, that needs a pressure gradient for the air to move into the alveoli. So you increase the mouth pressure, the air pressure at the mouth, so that it goes in. So when it flows inside the airway, because of the different diameter, it faces resistance. That we call it as the airway resistance. This airway resistance is measured as centimeter per liter per second. That means when you increase the speed, the airway resistance will increase. When you increase the flow, the resistance will increase. Likewise. So the importance of diameter of airway. The resistance will increase if you halve the diameter of the airway. That means it will increase by 4th power. So the lumen of the bronchus decides the airway resistance very much. So in bronchospasm, the airway resistance increases to 4th fold, so that the air cannot move in. So the first part of any treatment should be the dilation of the airways. And as in normal airway resistance, the contribution by the smaller airway is just 10 to 15%. The middle size lobar bronchi, they offer the maximum airway resistance for the airflow to occur. Naturally, if the airway resistance occurs, if the patient is not able to blow the air into his alveoli through the airway, naturally, he has to do more work of breathing. So patient will easily exhaust it. So airway resistance will in turn increase the work of breathing. So in the early stage, airway disease like asthma will affect the smaller bronchus. That's why they are not bothered in the initial stages, because the airflow may not be, the airway resistance may not increase much. Once the middle-sized bronchi are affected, go into spasm, the problem of increased airway resistance and work of breathing increases, the patient lands up in respiratory failure. And another thing is, the airway resistance, as I said earlier, it also depends upon the type of airflow also, whether it is laminar, that is smooth, or turbulent. So naturally, when there is restriction in the airway lumen, it becomes turbulent. If the airflow becomes turbulent, the viscosity and density will play an important role, especially density. If there is an airway constriction like tracheal stenosis, there is a turbulent actor, the flow is turbulent at that point. Suppose if you give a less dense gas, the movement of less dense gas through that smaller opening will be more. So that is the principle of giving heliox. This is turbulent. So helium and oxygen mixture, if you give in this type of patients, the flow will be more for the given respiratory effort. That is the advantage of Helios. Finally, a few words about the work of breathing. I have already mentioned you, the work of breathing may be affected because of the reduction in the distensibility, that is reduction in the compliance, or increase in the airway resistance. And normal work of breathing is just we are consuming 1 to 3% of our total oxygen consumption of 250 ml. When the person has got obstructed breathing or a stiff lung, naturally his amount of oxygen spent on breathing will become more and more. Even it may touch 25% of the total oxygen consumption goes to the breathing. So at that time, the other organs will suffer hypoxemia. So slowly the other organs will suffer hypoxemia and lactic acidosis may ensue. And breathing, the respiration will consume most of the oxygen what the patient breathes. So these are all example of how the work of breathing increases in restrictive disease and also obstructive disease. Both in both the condition, the work of breathing increases, but the pattern is little different. That's all. So the last point is, before I conclude, some interesting facts about the occurrence of pulmonary edema. This is very basic. So you have to understand that if you recapitulate your stalling force, the force of which decides the fluid to stay inside the vessel or to go out. If you calculate the fluid which is driven out with the forces which decides, which helps to push the fluid out is 29 millimeter, and the plasma oncotic pressure, colloid oncotic pressure is just 28 millimeter. So in pulmonary circulation, there is obviously there is an outward force is always favored. A small tilt in the balance will cause the fluid from the vascular side seep into the alveoli. So pulmonary edema is very easy to create. So at the same time, the capillary pressure has to increase from 7 to 28 to overcome the oncotic pressure to cause pulmonary edema. And if negative pressure in the interstitium, forced inspiration against a closed glottis is an example. When you develop extreme negative pressure in the alveoli also, it can also suck the fluid easily. That's what happens in the laryngospasm at the end of the surgery. When the person is not able to breathe against a closed glottis, that is laryngospasm glottis, at that time when he tries to breathe against obstruction, that time the inspiratory pressure is in alveoli is very high, so it sucks the fluid. So naturally, the pulmonary edema easily results. Likewise, if a person, a surgical patient, is already hypopronemic, this balance is easily tilted. He becomes very prone for pulmonary edema easily. But in chronic condition, lymphatic drainage is pepped up, so the pressure can be as high as 50 millimeter, but still pulmonary edema may not result. So the one word about the interstitial space in the alveoli, this is the interstitial space. Initially, the fluid accumulates here. That's why you are not able to hear the bubbling sound or crackles inside when you auscultate. So you may think that pulmonary edema has not occurred, but in fact, the fluid would have occupied the interstitial space, which may not be easily diagnosed by your clinical equipment. So at that time, you may need an ABG to prove that hypoxia has resulted. So what happens when you are ventilating during the surgery, when you give positive pressure inside the lung, the fluid will not come into the alveoli. They will be just accumulating in the interstitial space. So at the time of reversal, what happens? Patient is put back to negative intra-alveolar pressure during the spontaneous. So once the negative pressure is come here, immediately the fluid is sucked in. So alveoli will occupy, the fluid will occupy the alveoli. At that time, overt pulmonary edema will occur. So what you will think is, intraoperatively patient is perfect. I have given a beautiful anesthesia. Only during reversal, patient has developed a pulmonary edema. It is not so. If you can monitor the PaO2 intraoperative period also, you can pinpoint when the interstitial space is occupied by fluid and pulmonary edema has occurred. So that's why that is the idea of giving PEEP during the accumulation of fluid, especially in the interstitial space. When you increase the pressure, end expiratory pressure, naturally it drives the fluid from the interstitium to the outside of the lung. It redistributes. So let me summarize my whole lecture. We have come to the end. As I said in the first slides, surfactant plays an important role in its absent atelectasis results. And VQ mismatch is avoided by the relationship between the lung distensibility and the gravity affected perfusion. The lung at the lower part of the lower part of the lung is in ideal position to have a maximum inflation during a minimum increase in the transpulmonary pressure. The FRC is very, very important in maintaining the arterial oxygen saturation, and anesthesia decreases the FRC. And lung has to be optimally compliant. That's why the work of breathing has to be kept minimum, so that patients will use maximum is oxygen into some other tissue. And asthma and emphysema will affect the compliance and airway resistance in variable ways. And pulmonary circulation is very, very prone for edema. And anything which tilts the balance, even in a minimal way, patient will land up in pulmonary edema very easily. So you understand this basic physiology of lung in your, so that it helps in your day-to-day anesthetic practice. So that these are all the problems that can occur. These are all the problems that can give rise to pulmonary edema. So treat the basic, then you will easily come out of the crisis situation. So at this point, I should thank Dr. Edward, who is phenomenally active in teaching the students of Tamil Nadu and other states also. And he has come out for the past 1 or 2 years. I was telling him, it's very difficult to maintain the enthusiasm, Edward. Every week you are posting in a quiz program. Make it once in a month or once in 2 months, so that you will not be exhausted. But I haven't seen Edward being exhausted even now. So every week he is coming out with so many quiz programs. Whatever opportunity he gets, he doesn't fail in teaching others. Hats off to Edward, and I wish you all the success in your venture, and for all the participants. And I'm saying for the first time, the participants number, it is just like swelling like India's petrol price. From 50 to 300, it has reached within minutes. So very happy to see that so many participants have come, and hope it is useful for everybody. Thank you again, one and all.
Thank you, Selva. So over to Selva, sir.
Thank you, Selvakumar, sir. Selva sir's own style of teaching, creating the questions in the listener's mind, then giving a life-size example, and then explaining it in a very simple words, and making a difficult concept to be understood very easily. Thank you very much, sir. And we have a few questions, sir. I think almost many questions which the postgraduates asked have been covered in the lecture itself. There is 2 questions about PEEP. Sir, what is the ideal PEEP and how to find it out? And one is the other question is about the PEEP's relationship with the right and left ventricular output.
Yeah, even though they are out of my basic lecture, PEEP, you know that when you keep on increasing the end expirative pressure in the alveoli, the benefit it offers, that is driving the fluid out of the alveoli and increasing the size of the alveoli and keeping the airway without collapsing. These are all the benefits of PEEP. Once you keep on increasing the PEEP, they'll offer you many benefits. It keeps the alveoli open and drive out the fluid. But after a certain time, what happens when the PEEP increases, it exerts pressure on the alveolar wall. You know very well that all the vessels, they are in the alveolar, the infrastructure that is in the alveolar wall. So when you keep on increasing the alveolar size, they skews the pulmonary vessels. So naturally, the blood coming to the alveoli will be jeopardized. So what is the use in keeping the alveoli open and oxygen coming into the alveoli without the perfusion being happening? So that's why after a certain level of PEEP, the cardiac output starts decreasing. The second question, the right ventricular output, because the right ventricle has to pump the blood into the pulmonary capillary system. So naturally, when they are squeezed in the lung, when they are constricted, the right ventricle will face a lot of difficulty pushing against the resistance. So right ventricle will start failing. That's why the perfusion decreases to the lung. So there is no use in keeping on increasing the PEEP. So then there must be a situation called ideal PEEP. That is, when the cardiac output is not affected and maximum benefit on the respiratory mechanic occurs. That is called ideal PEEP. So you have to titrate the level of PEEP with your ABG, PaO2, and also the BP and CVP. So you have to correlate everything to find out the ideal PEEP. In which level of PEEP oxygenation is maximum without jeopardizing the cardiac output. So that explains the concept of ideal PEEP. So naturally, right ventricle gets the maximum stress because of the PEEP.
Nicely answered, sir. I think few more questions. We can answer these questions in our social media pages. I think that we find, sir. The questions on how to reduce the work of breathing and the ventilator setup to prevent collapsed alveoli. All these are already covered. We can discuss in the social media pages. Thank you very much, sir.
So one or two questions I can answer. The atelectasis, the type of atelectasis, what we are worried is atelectasis due to so many factors. Mainly is the absorption atelectasis because of high FiO2, and the damage. Atelectasis occurs because of damage to the alveoli, aspiration, and because of shallow breathing. When the transpulmonary pressure is not created effectively because of shallow breathing, or as another question has come, how to prevent postoperative atelectasis in upper abdominal surgery. Naturally, the upper abdominal surgery, patient will have severe pain because of incision. So patient will not take deep breathing. The diaphragm, when it descends down, that will input, mainly it needs abdominal muscle to relax and contract. So what happens at the time, patient will have severe pain. So he will not try to take deep breath. He will try to take shallow breath. This shallow breath will definitely lead to a reduction in the transpulmonary pressure. So the lower zone alveoli also goes into collapse called atelectasis. So these kind of atelectasis can be prevented by deep breathing. Deep breathing exercises are a very good pain relief. The upper abdominal incision, especially the subcostal incision and all, needs a very good pain relief, like regional, what you can go for a paravertebral or epidural or upper abdominal tab, so many things. So a regional anesthesia will give a complete pain relief. So patient will have a deep breathing, and this will prevent atelectasis.
Thank you, sir.
Yeah, I think we can wind it up.
Yes, sir. If there are any more questions, I can.
Selvakumar, can I add some more?
Yes.
So they asked how to prevent intraoperative atelectasis. What is the recruitment maneuver? So just applying a PEEP in the intraoperative period will not improve the oxygenation. As time goes, the oxygenation will fall. So for that only they have introduced the recruitment maneuver. What do you mean by the recruitment maneuver? You have to give a high inflation followed by a PEEP. So applying PEEP alone will not recruit the collapsed alveoli. You have to apply a hyperinflation, that is for 20 seconds 40 centimeter. Now they have come to 8 seconds 40 centimeter. You have to inflate for the lung for 8 seconds, then you have to go for a PEEP. So that is the way to recruit the collapsed alveoli, mainly in the case of laparoscopic surgeries. Thank you, Silva.
Yes, sir. I think the psi mechanisms in the critical care are also nicely described, yes, sir.
Yes.
Thank you, sir. That was a very nice lecture on this Sunday. Thank you very much, Selva, sir. I think we can go over with the quiz, sir.
Thank you, Selvakumar, for your wonderful lecture for the beginners, for the first years, and even the final. See, even Professor Kannan sir are attending this program at this age. Thank you, Kannan sir, for being with us. And we will move on to the quiz, I think. Thank you. I will share the quiz. So this second question, we go to the second question. What is the oxygen requirement for 70 kg adult? Whether it is a 150 ml or 250 ml or 350 ml or 450 ml. Shilpa, hold please. So they are nicely answering. So 250 ml, you need 68% can end the poll. So 69% they voted for 250 ml. We will see the answer. So 250 ml is the right answer because the oxygen requirement in adult is 3 to 4 ml per kg. Compared to the newborn, the oxygen requirement is 7 to 9 ml per kg. So how the newborn make up this increased requirement of oxygen? So the newborn increases the alveolar ventilation to meet the increased requirement. But in newborn and adult, the tidal volume is the same, 7 ml per kg. Then how they make up for the increased alveolar ventilation? They try to increase the respiratory rate and try to increase the alveolar ventilation, even with a fixed tidal volume of 7 ml per kg. Likewise, the carbon dioxide production is also high in newborn, and increased alveolar ventilation reduces the PaCO2 to 38 to 40 mmol. So coming to the third question. So during a normal breath, say a tidal volume of 500 ml, the transpulmonary pressure increases from 0 to 5 centimeter of water. So the product of transpulmonary pressure and tidal volume, that is 500 ml tidal volume into transpulmonary pressure of 5 centimeter equal to 2500 centimeter of water per ml. So this expression, we need not go into the calculation. The expression of the pressure volume relationship during breathing determines what parameter of the respiratory mechanics. This was nicely explained by Selvakumar in his lecture. So whether it is a lung compliance, air resistance, pulmonary elastance, or work of breathing. Hold please. We need not go into the calculation. So you remember the pressure volume relations. No. Most of them are answered lung complaints. But we will see the answer. So it is work of breathing. He already explained the work of breathing depends upon the two factors. One is the resistance developed in the airway. Another is the elastic forces of the lungs. So the resistance and elastic forces are taken into account. It is a work of breathing. So how the work of breathing is more important? Work of breathing increases when the patient's respiratory rate increases. That means the minute ventilation has to pass through the airway, so the airway resistance has increased. So the work of breathing increases. Likewise, when the patient take a deep breathing, the alveoli has to extend a large. So the work of breathing also increases. So the two ways work of breathing increases. One is taking deep breath, and another is the increase in the respiratory rate. So any normal individual or individuals with a lung disease, they try to adapt themselves to lowest work of breathing with better oxygenation. So what happens, you see in the first picture, so the elastic resistance airway flow is both resistance causes the work of breathing. So the work of breathing is less at the respiratory rate of 15. So coming to this fibrosis or restrictive lung disease, there is increased elastic resistance. So in that case, the patient adapts himself to higher respiratory rate, more than 15, around 18. So around 18 respiratory rate only the work of breathing is less. So these patients with restrictive lung disease take a shallow, rapid respiration. So coming to the obstructive lung disease, so these patients have deep and slow respiration. So they adapt themselves to a lower respiratory rate where the work of breathing is less. So this is the way of adaptation of a normal individual and the patients with lung pathology towards the work of breathing. So coming to this fourth question. This question is also explained by Selvakumar in his lecture. So which of the following statement concerning the distribution of oxygen and carbon dioxide in the upright lungs is true? PaO2 is greater at the apex than at the base. PaCO2 is greater at the apex than at the base. Both PaCO2 and PaCO2 are greater at the apex than at the base, or both PaCO2 and PaCO2 are greater at the base. So which one is correct? Poll please. If you listen to Selvakumar lecture, the answer was there. I need 50% at least pass the correct answer because it is discussed in the lecture. So we will end poll. So 44% have given the right answer. So the ventilation perfusion ratio is greater at the apex. So the dependent lung is hypoxic and hypercarbic. If we see this is 132 is the PaO2 in the upper lung because it is more ventilated. Then here it is 89 only. So the lower segment is hypoxic and hypercarbic compared to the upper lung. So coming to the fifth question, you calculate the dead space ratio to the tidal volume, that is physiologic dead space ventilation, based on the parameters, that is PaCO2 is 45 mm and mixed expired carbon dioxide is 30 mm of mercury. It is 0.1, 0.2, 0.3 or 0.4. For this, you must know the equation. Poll, please. So dead space equation you must know. So most of them are answering correctly. What happened? Okay. Okay, for around 50% answered correctly. So we'll go to the answer. So you must know the Bohr dead space equation. If you know the Bohr dead space equation, you can calculate the ratio of the tidal volume, dead space to the tidal volume. It is normally 1/3. That is, if the tidal volume is 450, the dead space will be 150. So this goes by this equation, that is PaCO2 minus PE, the end-tidal carbon dioxide, PeCO2 divided by PaCO2. Here they have given PaCO2 of 45 and end-tidal carbon dioxide of 30. So it is 15 by 45. So it comes around 0.33. So it depends upon the Bohr dead space equation. So coming to the sixth question, we have 10 questions. So maximizing which of the following lung parameter is most important factor in prevention of the post-operative pulmonary complication. This is also discussed by Selvakumar in the lecture. Whether it is increasing tidal volume or inspiratory reserve volume or vital capacity or functional residual capacity. Poll, please. So almost first it gone to 100%. Okay, done. Very good. So obviously it is functional residual capacity. So you know the functional residual capacity is the amount of air remains in the lung after a normal inspiration. I already told. The amount of air remain in the lung after a forced expiration is residual volume. The difference between these two is the expiratory reserve volume. So you have to increase the closing volume is the lung volume at which the small airway close. We already told closer volume is the lung volume at which the small airway closes. So you have to maximize the FRC, therefore reduces the atelectasis. You have to maximize the FRC above the closing volume, then only you can prevent the atelectasis. So how to increase the FRC at the post-operative period? By early ambulation, by using incentive spirometer and taking deep breathing exercises, and you can also use intermittent positive pressure breathing. So the seventh question, the FRC is already it's a part of the above question. The FRC is composed of expiratory reserve volume plus residual volume, or IRV plus residual volume, or inspiratory capacity and vital capacity, or expiratory capacity and vital capacity. Poll, please. So you almost understand the lecture. So it is expiratory reserve volume plus residual volume. So coming to this, these are the normal lung volumes and capacities. Here, if you see the functional residual capacity, it is 2400 ml. The residual volume is 1200 ml. So the expiratory reserve volume is 1200 ml. So adding this residual volume and the expiratory reserve volume, 2200 each, it comes to the 2400 ml. So it is easy to remember. The residual volume is 1200 ml. The functional residual capacity is 2400 ml. So obviously the expiratory reserve volume will be 1200 ml. So other volumes you have to remember is the vital capacity. It is 60 to 70 ml per kg. That is 4500 ml. And your total lung capacity is around 6 liters. So coming to the 8th questions, an intubated patient is breathing 30% oxygen in a critical care unit in Chennai. Why I am saying is Chennai is at the sea level. So the arterial blood gas analysis reveals PaO2 of 140 and PaCO2 of 40. So which of the following best represents her alveolar arterial gradient? So if you want to know the alveolar arterial gradient, you have to calculate the alveolar oxygen. So whether it is a 6, 10, 12 or 18 or 24, you never forget the alveolar gas equation. It is commonly asked question in every exam. That is the basic alveolar gas equation. If you don't know alveolar gas equation, the examiner will fail you. So that alveolar gas equation you have to use here. I don't think you got my point. So most of the answers are wrong. So this is alveolar oxygen tension is more important. That equation is what it says is FiO2 multiplied by the atmospheric pressure minus water vapor minus PaCO2 by 0.8. This is the respiratory quotient. So the FiO2 is the fraction of the inspired gas. Here it is 0.3, 30% is using. And I said it is a sea level. So 760 mm of mercury minus, suppose take 100% humidity, the water vapor pressure will be 47. So 760 minus 47. PaCO2 is given, that is 40 divided by 0.8. So it will come around 250 minus 50, it is 164. So it is come around 164. So the difference between this 164 and our measured PaO2, that is 40, the difference is 24. So there is a 24 mm of mercury of difference between arterial and alveolar oxygen tension. Why alveolar arterial oxygen tension is more important? So this is taken from the Nuns Applied Respiratory Physiology. A rough calculation of the arterial and alveolar oxygen difference is age by 4 plus 4. It should be less than this. So as a normal gradient increases with age and also FiO2. For an 18-year-old non-smoker, the gradient will be 5 to 10 mm of mercury. So elderly person, it will be increased to 14 to 15 mm of mercury. Suppose you are giving 100% oxygen, the gradient will be increased for 30 mm for a normal individual, and it will be higher for the elderly people, so around 50. So the AA gradient also help us to differentiate the type of hypoxia. Suppose the patient is in hypoxia and he is having a normal alveolar arterial oxygen gradient, that means the patient has an alveolar hypoventilation or low FiO2. Suppose you give high FiO2, the patient will come out of the hypoxemia. Suppose the patient is hypoxemic and he is not, has an elevated AAA gradient, means it may be due to VQ mismatch or left to right shunt, or it may be due to diffusion impairment or decreased venous mixed oxygen. Decreased venous admission. It may be due to sepsis, fever, or thyrotoxicosis. So coming to the 9th question. So from the time that apnea is initiated, how long will the patient oxygen stores last until he begins to desaturate? Imagine this patient is breathing air. So starting from the apnea, how long he can be avoided the hypoxemia? It is 30 seconds, 60 seconds, 2 minutes, 4 minutes, or 6 minutes. Poll, please. So normal patients breathing air, how long he can withstand the apnea? I have already told you, patients taking 100% oxygen, they can withstand apnea up to 8 to 10 minutes. 6 to 8 minutes they can withstand without hypoxia. That is the SpO2. Preventing the SpO2 fall below 90%, they can manage up to 6 to 8 minutes. Suppose that same patient is taking air, how long he can prevent hypoxia? So most of them are correct. So this is the 2 minutes. How it is 2 minutes? So the pulmonary oxygen stores at time of 0, the volume of FRC is multiplied by the FiO2. The time of 0 means at the end of inspiration, how much the FRC, the oxygen in the FRC, you can calculate. How to calculate the oxygen at the time of end of inspiration? You have to multiply the FiO2 with the FRC. So FRC is 2400 ml and your FiO2 is 0.21. Then the oxygen in the alveoli will be 504 ml at the beginning of the apnea. So the oxygen consumption per minute is 3.5 ml per kg. For a 70 kg, it will come around 245 ml per minute. So the patient will be taking 250 ml of oxygen every minute from the alveoli. The alveoli is already having only 500 ml of oxygen after the beginning of the apnea. So the patient FRC can withstand the oxygen storage up to 2 minutes. Then the patient tend to desaturate. So this is the way to calculate the reserve oxygen in the FRC. So coming to the last question. A pulmonary artery catheter is placed to monitor the pulmonary artery occlusion pressure. In which west zone? You know the west zone 1, 2, 3. In which west zone must be the catheter lie in order to be accurate? Whether it is a west zone 1, 2 or 3 or 1 and 2 or 2 and 3. Poll please. Poll please. Shilpa. Shilpa, poll please. Are you there? We can go to the answer. So answer is already displayed. It is nice to see more than 100 people are attending this quiz. Thank you. So most of the answers are correct. So it is zone 2. Why zone 2? It is a big question. Why not zone 1? Why not zone 2? So the pulmonary artery catheters estimate the left ventricular end diastolic pressure after occlusion of the bulb. So it is called wedge position. So the pressure measured at the catheter tip is in continuation with the end of the left ventricular end diastolic pressure at the time when the mitral valve is open. At the end of diastole, when the mitral valve is open, the whole thing, that is the pulmonary bed, pulmonary veins, and your left atrium and left ventricle, all will act as a conduit. It's a water column. Then only it can measure the pressure in the end of the left ventricular diastole by this pulmonary artery catheter when the wedge is open, then when the balloon is open. So for measuring a blood-filled column, the tip of the pulmonary catheter should be in the zone 3, because zone 3 is the highly perfused area. Suppose already Selvakumar explained, when there is a hypovolemia, you are applied PEEP, the zone 3 is tend to be converted into zone 1 or 2. So in that situations, measuring the left ventricular end diastolic pressure by this pulmonary artery catheter will be a false one, because the air pressure will interfere with the water column. I will explain the next. So this image, you closely follow this image. The pulmonary artery catheter is in the pulmonary artery. Now the bulb is inflated. So the sensor is in the left side. For the patient's point of view, it's left side. So the right ventricle pressures are out of question. Now it measures only the left ventricular pressure, the pulmonary artery pressure. So pulmonary capillary bed, pulmonary venules, veins, left atrium, and finally to the left ventricle. This all acts as a water column when the mitral valve is open at the end of diastole. So this pressure now measures the end diastolic left ventricular pressure. Suppose, so the ideal space is zone 3. Suppose you apply PEEP, what happens? This zone is converted into zone 1 and 2. That means the alveolar pressure is above the venous pressure and alveolar pressure is above the arterial pressure. So the pressure measured by this pulmonary artery catheter will be the only the airway pressure. That is the PEEP pressure. So it cannot measure the left ventricular end diastolic pressure. So that is the disadvantage of having pulmonary artery catheter in other zones. So you have to keep the tip in the zone 3. If the patient is hypovolemic and there is applied PEEP, it will be converted. The zone will be 3 will be converted to 2 and 1, and it will give a error. So with that, I hope you understand that. With that, I end up the quiz. So my questions are taken from this comprehensive review, Brian A. Hall, but my answers are from my preparation. Thank you, one and all, for a wonderful first session of my online anesthesia. So I thank the speaker, Selvakumar, Vinoth Kumar sir, and all the attendants, participants. I am overwhelmed by your response. There is more than 300 people attended these sessions. We will meet you on the next sessions. Until then, I am signing off, Dr. Edward Johnson. So this is a online anesthesia postgraduate teaching program sponsored by Acrola and hosted by A1 Logist. Thank you, one and all. We will see you next week. Thank you.